Kristen Wendorf has worked and specialized in TB treatment, prevention, and policy for the California Department of Health since 2017 and has specialized in pediatric critical care and global health. Currently, she serves as a clinical consultant for the state of California, as well as for the CDC's Curry International Center with a focus that includes pediatric TB and MDR TB. And her talk today is called TB disease or TB infection, which is always impossible for me to figure out in kids. So I hope to learn something and take it away, Kristen. Thank you.
Hey, nice to meet all of you. I lived in Seattle for 2 years, so I'm always like happy to see you guys. I loved living there. It's a great place. Please feel free to throw comments or questions in the chat. I'd love to discuss whatever you guys are interested in discussing. I have 9 cases we can run through if we don't get to all of them because some are more interesting. I think that's great. So, please interrupt me. Please write in the chat to make this kind of more fun and interesting. So I'm going to start with a tiny bit of background. I don't have any disclosures. A couple slides of didactics, and then most of this is going to be kind of going through some cases and seeing what you guys think. So I think the basic take home, if you get nothing else from this talk, is that pediatric TB isn't just like one thing. Pediatric TB is really different according to the age of the child. So that's the kind of thing I want to set up at the beginning. So this is a graph of all of our pediatric TB cases. So cases we included up through age 24 here. So this is every year of life. This is our cases in California under less than 25 years old between 2000 and 2023. And I hope what you can glean from this is that we have a large number of cases under age 5, and most of these kids were born in the US. There's really not a whole lot of cases between like 5 and 17 years, particularly in that like elementary school, junior high range. And then we really see cases start exploding kind of after high school graduation, and the majority of these cases are non-US born and kind of mimic more closely our adult TB population in the US. The other thing that's really different according to age is the type of TB that kids get. So I wanted to draw your attention. This is kind of the same sample size of a bunch of cases. This is about 8,000 cases total. So 5 to 17-year-olds in particular have a lot more extrapulmonary TB only, so a lot more scrofula and other places you have to look outside of the lungs. And then the under 5-year-olds, you guys probably know this, but I just thought interesting to throw out there. We found that 8% of our cases under 5 had CNS TB, which is really a high percentage. So this is really, should be within the non-pulmonary TB, but I thought just important to throw out there. The next thing that's really different is how we confirm TB disease, and this is why LTBI versus TB disease is so hard in young kids. So essentially our 18 to 24-year-olds, we're diagnosing like adults, we're getting good samples, it's telling us whether or not they have TB, and we're making some clinical decisions, but a lot of it is this getting good samples and trusting them. 10 to 17-year-olds, you can generally do that, but there is, like I just showed you, more extrapulmonary TB, so sometimes getting those samples and the correct bacilli is a little bit harder. But really under the age of 10, most of these TB diagnoses that we're making are entirely clinical because your cultures either don't grow or you're not able to get a good one. So this is, I think, one of the big separations. I kind of think of age 10 and older, more adult-like, and under age 10 as a little bit less adult-like. A paper that was published recently from Moraes et al. So kind of laid out the natural history of TB disease in children kind of before antibiotics were available. And what I think was really important from this paper is laying out, that we talk about under 5-year-olds, but even under 5-year-olds are not all alike. So particularly for kids under age 2, you see a much higher rate of developing TB disease after they're exposed, and then a much higher rate of TB meningitis or miliary disease. I think our data kind of showed that in California as well. But once you get to like even age 5 to 10 years, your risk of developing TB disease really, really goes down. A sad correlate to this is when we had a researcher here who was PedsID who reviewed all of our CNS TB outcomes. So looking at how did kids do, she collected medical records to say years after you had CNS TB, how were you? Did you get back to your baseline or did you have permanent long-term like neurological sequelae? And what she found was that really, the young kids up to 1.5, 81% had really poor outcomes for those who had CNS TB. Once you got to 1.5 to 4 years, the outcomes improved a little bit, but still the vast majority of children are having moderate sequelae, at least. And 5 to 18-year-olds, you see only 16% had poor outcomes, and actually 58% had no sequelae of their disease. So again, kind of a side where you're thinking about, the outcomes of disease and what you're worried about is really different by age. The last thing that I want to point out that is different, just because it's going to come up in some of the cases that I talked to you about, is because of this really high risk for TB progression in young children. For kids that we know were recently exposed to TB, we want to consider treating them if we don't find evidence of active TB when they first get evaluated. Even in that period where an adult and older kids will say, if you had a negative baseline TB test and you look great and you have a normal chest x-ray, we'll just kind of wait until we can do that definitive test at least 2 to 10 weeks after your last exposure to TB, because we know that our TB tests require the cellular immunity that takes time to develop. But in young kids, we're not really comfortable just waiting off treatment because we know they can progress quickly. So we often want to put kids on, it's essentially LTBI treatment in this window period if we don't find active TB. So what I think this brings up is particularly in kids under 5, and again, kids under 2 who are really high risk. If they had a recent exposure to TB, you really want to decide quickly, am I comfortable putting this kid on, one drug for a window period, or do I need to start more than one drug because this kid might have TB disease? And Dr. Dabity made this slide, which was amazing. So I think I've kind of laid this out, but I think as a background, the kids under 5, you're primarily making a TB clinical diagnosis. These kids have a really high risk for progression, severe disease, long-term outcomes. And even when you get your cultures, you can't really trust a negative. Really young kids, you might not even trust a negative skin test or IGRA. So probably, and I learned this from Dr. Loeffler, who I think a lot of you guys know, I probably overtreat this group because I'm worried about the negative outcomes. So this is kind of a unique group. I think most 5 to 9-year-olds, again, there's a lot of extrapulmonary TB where maybe you're making a clinical diagnosis, based on your TB tests. But usually you can get a good specimen, and if you're confident in your good specimen, I think you can trust it. But again, with extrapulmonary, that can be tricky. And once you're 10 years in age and older, I think generally you can get good samples and you can trust them. There are always caveats, but that's kind of how I think about kids. All right. So a quick overview of how I think about making a clinical TB diagnosis for these younger kids. So it's essentially weighing the risk of TB disease versus the risk of missing TB disease. And so I think about, the epidemiology, what the investigation was around this kid's possible exposure to TB, what the kid looks like, and we'll talk about pediatric specific evaluations, and then what you found according to your TB tests and your chest x-rays. Your epidemiologic risk, I think of the environment and the extent of exposure. I feel like we all are more comfortable with this after COVID and thinking about this a lot, where you get exposed to respiratory diseases, but also from, the adult index case, if you know who that is, any features associated with contagiousness and any evidence of transmission. I find evidence of transmission really useful, especially in young kids in large households who are exposed to TB. When you can't trust the TB test because the child is really young, sometimes you can glean information by everybody in the family is newly IGRA positive or everybody's IGRA negative. It doesn't mean for sure, right, that the kid was exposed or not exposed, but gives you a sense of evidence that the maybe index case was contagious that you can use to help you make a decision. This is a chart I pulled from Jeff Stark's Handbook for Child and Adolescent TB, just listing some of these features that we think of that could be indicative of contagious TB. You guys probably know these: coughs, cavitary lesions, smear positive, and especially in environments with poor ventilation, which a lot of times is homes, smaller living spaces with lots of people is where we tend to see lots of TB transmission to children. So part of the clinical evaluation for kids that I think is a little bit different than adults is including a growth curve and seeing where your child is and how they have been growing. TB symptoms and physical exam, taking into account again that a lot of kids are going to have extrapulmonary TB at a much higher rate than adults. And so thinking outside of just the lungs. I think an IGRA is just a better test for most kids. So I'm just going to use that as my example for most of these. And then a chest x-ray. We just published this recommendation PDF. It's maybe like 3 or 4 pages on our website. Like there's a QR code for it. The reason for throwing this together is that we found in some areas of California, even children identified as contacts of TB disease were being sent to their general pediatricians for evaluation because there wasn't someone in the health department who felt comfortable seeing kids. And we found that some general pediatricians had never been trained on TB and didn't really know what to look for. So this is a quick document. There are 2 flow diagrams associated with it to kind of help you walk through LTBI versus TB versus window treatment. So this is the over 5-year-olds. So it doesn't really include window treatment. The under 5-year-olds, you'll see it's kind of more tricky, the age of the child, and whether or not you're going to use window prophylaxis. But I don't know if putting these QR codes in case they're useful for your population. So this is my final slide. Pediatric TB is not one size fits all. It depends on the age of the kid. It depends on the risk for the kid. For kids under 5, use all the things you have. Consider repeat imaging, consider a CT scan if you have access. Kind of put all your pieces together because it's going to be a clinical diagnosis and your risk of missing is pretty high. So I find comfort in over-treating. I learned that from Dr. Loeffler. So, and your older kids, I think you can kind of think a little bit more. Kind of like you would think about an adult patient, getting samples, making sure you get good samples, thinking about how things work together. Always get your lateral because that's going to help a lot in the kids. You're really looking for a lot more adenopathy. And don't treat TB infection unless you exclude TB and the child as well. So let their community-acquired pneumonia get better before you treat them. And always call a friend. I call the other PD experts a lot, all the time. Probably too much, but it's where we get all our good cases to share from.
Thanks, Kristen, for a great talk. A lot of thank yous in the chat, and we went a little over, but by virtue of the fact there's still 100 people on the call, I think it speaks to people being really interested. So really appreciate it, and we hope you come back again.